Very good morning, all of you. And on behalf of the Pune Knowledge Cluster, I welcome you to the session today in this course of understanding and exploring epidemiology. And for today's session with us, we have Dr. Babasaheb Tandale. Uh, Dr. Tandale is an MBBS, MD, and he also has a postgraduate diploma in bioethics. He is scientist F and the group leader for the epidemiology group. He's associated with the Indian Council of Medical Research, ICMR, and National Institute of Virology, which is NIV Pune. Dr. Tandale has worked earlier as an epidemiologist, come lecturer in Indira Gandhi Government Medical College, Nagpur, from 2001 to 4. Immediately after completing his MD from the Government Medical College, Aurangabad, during 1997 to 2000, Dr. Tandale joined ICMR NIV Pune as a medical scientist, specifically as an epidemiologist in September 2004. Being the senior medical scientist and group leader of epidemiology group, his work involves outbreak, spreadness and response activities, including field investigations of outbreaks. So he is involved in outbreak response for over 50 outbreaks over 15 years at ICMR NIE. He has worked on pandemic H1N1, flu, bird flu, chikungunya, dengue, forest disease, West Nile, also COVID-19, etc. He has also undertaken surveillance research, seroepidemiological surveys, and field studies on outbreak-prone, vaccine, preventable, endemic, and emerging viruses. Field evaluation of vaccines are also undertaken for safety, immunogenicity, efficacy, coverage, and effectiveness during the field use. He also has guided master students and trained researchers on epidemiological skills. Recognizing the significant and impactful research contributions made during epidemic, ICMR honored him with award in 2010 and in 2014 for epidemiological research during outbreaks. He is currently working on virus disease, burden studies, their prevention and control research, along with field evaluation of mobile application for immunization. So we are very happy to have you here, sir, today for the talk, and over to you.
Thank you, Prachi, for this detailed introduction, and I'm honored really to be part of this great initiative for making youth understand, scholars understand the importance of epidemiology and how it is applied in public health and clinical medicine. So without much delay and due to the time constraints, I will be rushing through the slides because I have been already informed that most of these key concepts have been covered in earlier part of the course. So I'll move forward with the outbreak investigation talk that today we are discussing about is the outbreak investigation as a process, and we'll discuss everything in this course lecture. Prachi, can you move the slides? I'm not able to move, please.
Okay. So basically the screen is shared from your end. So maybe you can scroll your mouse, the scroll.
Yeah, I don't know, it is not happening. Earlier it happened when we actually tried.
So you can stop sharing the screen and reshare it again. So that...
Okay, please.
Racha, are you sharing?
So, maybe we can try once, sir, sharing it.
Okay. Okay, now it is moving. Sorry for that issue.
Yeah, it's visible now.
It's visible.
Yeah, now we can go ahead. So the outline of this talk would be like orienting on what are outbreaks, different terms that are used in outbreak related similar terms. Key areas that are needed to be understood as outbreak preparedness and response. We'll then move to actual investigations with specific roles that rapid response teams, RRTs, have to play. The specific areas of contributions that are expected from outbreak mitigation team. These are like verifying the outbreak if it is true outbreak, then confirming the diagnosis, describing the outbreak characteristics in time, place, person. Then going ahead with risk factor and exposures and risk groups identification for making the prevention control measures applied so as to have that outbreak controlled. And then we'll go with the stepwise investigation of outbreaks with examples in between to explain the concepts and the steps. We'll deal shortly later with laboratory response during outbreak investigations, and then move to the known and unknown disease outbreak situations. What are the differences and scenarios you may have to maybe deal with when we are going for outbreak investigation? And then we'll summarize and key messages at the end. So ground zero, outbreaks and investigations are becoming important with various reasons globally, and that is why we need to be actually making people aware, including youth and community aware of what are the likely public health threats, and that could be due to emergencies caused by epidemics or natural disasters and leading further to the outbreaks following that. I don't know, again, it has stopped.
Okay, so let me.
Prachi, it is better
Yes.
if you can as a host.
Yeah, I will share it. Yeah. So is the screen visible?
Yeah, move further. You can make it page down. Yeah, so next slide, please. So let us first understand what are the outbreaks and epidemics as the terms that are in use. So outbreak is actually occurrence of cases. Cases will define later on in the course lecture. What are the cases and understand that. But occurrence that is in excess of expected numbers. So what do we want to know always is what is the expected frequency of disease occurrence in specific communities. And that is the part of the surveillance activities that are undertaken by IDSP. You have had earlier lecture talking about what is being done to understand what is the expected frequency and numbers of cases. Then we define outbreak and epidemics in different terms of scale. Outbreak is usually limited to a small area with one district or below the district, like few blocks only reporting cases increasing. Then is epidemic, where this covers a larger geographic area, and this is linked to the measures that are needed beyond district or state in some cases because of the spread and extent of the outbreak. There is no exact threshold defined, but the word is maybe some of the times used interchangeably, and this is because there are legal implications for the term epidemic, use of term epidemic in India, Epidemic Diseases Act, some of you may be aware of. Next, please. So the key areas of outbreak management include preparedness, response, and research. If you are actually interested in taking up research activities in outbreak investigation, that could be the third component. Preparedness being it is to be ready, so that we are ready to deal with whatever outbreak happens and to investigate and maybe respond and control and take the research activities also as needed. So the investigation includes counting the cases that requires surveillance and investigation in field. Then we generate hypotheses or assumptions, what it could be likely caused by. That is due to that is possible with descriptive epidemiology aspect, and then we test the hypothesis with analytical epidemiology, that the designs that we use for understanding risk factors and causes. Then we control these outbreaks, and the control activities span in the entire outbreak period, not at the end. Next, please. Next, please. So we'll see what outbreak preparedness is. So preparedness activities are listed in this slide. So first and foremost is you have to have a designated pre-identified rapid response team, where if you are required to deal with outbreak in public health department or agency, or like in NIV, we have a rapid response team identified in advance and trained. Then we have regular review of surveillance data. You get to know news reports that are coming on. We could talk to people, public health authorities, clinical experts, that what they are seeing and what is the unusualness in that. So we identify the outbreak seasons. We know that which diseases occur in which seasons, which diseases are endemic or known to occur in which regions. Then we identify the specific laboratories that can support. And we are one of the laboratories, national level laboratories, contributing to diagnosis and research. Then is the designation of vehicles, because you need to move very quickly with the information coming in to respond. Then we have communication channels set up. So who will communicate to whom? What would be the decision-making authority, like a response center, emergency operation center, all that needs to be in place. Then is providing necessary drugs and materials required for the investigation and response activities. Next, please. So the detection of outbreak, definitely next, please. Next, please. So this is based on two aspects. One is the sources of information could be one, that is you are taking care of new events happening and the news and rumors or whatever news channel reports that are coming on, you are tracking that to see whether something is happening in some area that is unusual or maybe in large extent that needs response. Then is community informants can be another source, that you can have some community volunteers identified, that they will keep tab on what is happening in community. Is there anything new that is happening? And then media definitely plays a role to detect the outbreaks, and then we undertake the activities in response to that. Case-based surveillance is one of the activities that is being done by IDSP for some important public health problem and diseases. And others can be syndromic surveillance that is also being undertaken by IDSP for weekly reports of outbreaks happening in different parts of India. Next, please. So early warning signals definitely for the outbreaks could be clustering. And I think clustering is that cases are occurring in a time and place in a single location for more number of cases, that is clustering. That should be both time and place, not only time or not only place. That will not explain the clustering in support of outbreak. Then increase in cases or deaths, that more number of cases are happening. Single case of epidemic potential disease, like you may have seen Zika in Maharashtra or other states also. So some of the important diseases, newly emerging diseases, a single case defines outbreak. Febrile illnesses of unknown etiologies. We don't have explanation for fewer outbreak happening. Dengue, chikungunya, lepto, malaria, everything is negative. So we actually consider that as early warning sign to respond and investigate. Two or more linked cases, because measles, like measles and cholera or JE, and a plague is an international notifiable disease. We should have a tab on what is being reported, and two or more linked cases happening is an important pointer to respond to that situation. Unusual isolates. Unusual virus or definite genetic characterization is important, that if there is something shift or variants are coming, that also is early warning sign. Then is shifting in age group. So if you see cases happening in children and then moving to adults, or first in adults and then to children, this is real early warning sign that we have to respond. High vector density in diseases that are virus or related to vectors. And the natural disasters definitely, if they are happening, like flood in Chipudum. So definitely there are possibilities of water and vector-borne disease outbreaks happening in that area. Next, please. Next, please. So in response, definitely, as we have seen, rapid response teams, we have to be formulated in advance. There are usually three members in a team. And if you know this epidemiological triangle, then in that case, each one of these experts are representing these three triangle cones, the angles. So agent, usually a microbiologist, environmental specialist is epidemiologist or public health specialist, and host is human being, mostly because you are concerned of human beings. Clinicians should be part of the team. They should investigate and confirm the outbreak and its extent, and they should assist in the investigation and response by the local public health department. But the primary control activities rest with the local public health department. You are just as an advisor. Next, please. Deputing RRTs requires some of the important aspects to be considered. So we have to review the source and mode of transmission if it is already reported in news or health authorities. If not, then consider team with different backgrounds, and then consider the hypothesis, what it could be likely caused by, like agent or risk factor or transmission mode or a source of infection. All these need to be decided, including risk groups. And then you have to decide whether to get, if it is already well-known outbreak like dengue or chikungunya, you know what is it caused by and how are the risk factors. You can directly start controlling and then take additional activities of research, maybe if needed, but not as a priority. Next, please. So in terms of deciding whether to investigate or control, so this is the actually table giving the details of, if etiology is known, so control is the priority. If etiology is unknown, investigation becomes the priority. So this is how, and another aspect that is important is source of infection or mode of transmission. This is the most important contributor to help prevent and control the outbreaks. So if you know how it is being caused, then you definitely can control as a priority. Next, please. So we'll move now to the outbreak investigation as such, specific objectives. Next, please. So these are the 5 different specific objectives, as I already mentioned on the outline slide itself. This is first and foremost is it outbreak and is it a true outbreak? Recognize the magnitude of how large is the outbreak, what is the magnitude and extent of this outbreak. Diagnose the agent, etiology or cause, what it is caused by. Next is identify the source and mode of transmission, so that lastly we can have prevention control activities for that outbreak instituted. Next, please. Now, this is the important area and slide that we are actually going to dwell and discuss a lot on this in a methodical stepwise manner. So these are the 10 steps. I will not read out here. I will have that individually then discuss later on. Next, please. Next, please. So the first is we have to determine whether there is outbreak. Next, please. So for this, what we have to do is we have to define first outbreak, and we have to consider the incidence increase in given place and time. You need to know how early these cases started increasing, which areas are getting affected. So for this, the elements that are needed are numerator, that is number of cases that are on record. Denominator is the size of population that these cases are coming from. And then additional information can be the baseline over maybe last 3-4 years. What was the incidence of this disease in this area? Next, please. So to verify, there are issues in verification that we need to consider is the source of information first. Is there a change in reporting system? So if there is a change in reporting system, case definition is changed, or there is intensification of surveillance, definitely cases are going to increase. Then next is population size, migrations, important aspect that due to COVID, you know that people actually move to their villages. So the population residing in cities move to the rural areas, increasing the denominator there. So this is an important aspect that needs to consider. Acute reporting of old or chronic cases also. You have seen that cases that are not yet settled, whether it is confirmed or not, or whether this death is associated with diseases or not, then it will take some time to include these cases as cases or deaths, and that will make an issue in the numerator also. Next is about the talking to the concerned medical officer of that area. What is his perception? Is this the abnormal increase? Is there a clustering in time and place in some villages if it is reporting higher? Epidemiological link, is that the contact and related transmission, triggering event, if there was any festival or maybe some event that led to this kind of outbreak, and are there deaths that are not being explained. Next, please. Pseudo outbreaks is a very common encountering aspect that we have to deal with because of the increasing awareness and the prevalent cases getting reporting as incident cases that can happen in some of the chronic diseases or maybe some of the infectious diseases also due to delay in diagnosis. Laboratory errors also can happen, and some of these cases may be falsely labeled or maybe due to maybe false definition or maybe wrong definition. They are ascribed as these are the cases that needs verification. So as to have that true outbreaks. Rapidly changing population we have discussed, hospital seeking, healthcare seeking patterns, migrations, refugees, and other factors can play a role in denominator increase or decrease. Next. So we have done with the first step. The second step is confirming the diagnosis. Next. So for confirming the diagnosis, we have to gather the clinical information. And that best possible source is the clinicians or specialists that are actually investigating and managing these patients. We have to shortlist number of probable diagnoses they are giving, and maybe that physicians are not having detailed information about what can be the cause. But these are very usual first pointers to what could it be like as an agent. Next is seeking the laboratory information in terms of the confirmations and routine laboratory investigations also being done on some selected patients. Next, please. So third step is then we have to define a case based on these first steps. What is the case? That case can be defined as, next please. So prototype case definition usually is in this format. A case is an event and not a person. So that you have to keep in mind. It is occurrence, that is event, of spill out the disease. You can indicate disease or syndrome, right? And in a resident or a visitor, you can have a visitor also because case-based surveillance would be happening for travel-related infections. And that leads further to the local clusters and outbreaks. Then you have to indicate the location and two dates, start date and end date of interest. That is what a case definition prototype would be like. So there are various types of case definition given by different agencies. In India, we use IDSP case definitions. WHO and CDC also provide definitions for unusual and rare diseases that are there. Next, please. So case definitions, there are different levels of certainty. Based on certainty, they are defined as suspect, probable, and confirmed. So potential cases search needs to be there, and this search should be with a specific case definition that we have to follow. And the case definitions to be defined are to be sensitive enough that these are able to detect most of the cases. Maybe some false positive also would be there. False cases also would be there that can be refined in a later phase. So descriptive stage and analytical stage, if you have, case definition can be more sensitive in descriptive aspect, and analytical could be a very specific definition. And these definitions can change in due course of outbreak investigation. Next, please. So case definition types, as I indicated, these are possible or suspected cases that are usually considered as cases following investigation. So if you are not yet investigated some case, and then you say it is a suspect case, this is wrong. So what we have to do is, we have to do all your investigation of that case and see if it fits in the definition of suspect case, then label that as a suspect case. Probable is usually a clinician believes this is a case of measles or dengue or whatever. So that becomes a probable case. If physician is giving inputs and is labeling that. Confirmed cases are usually with the laboratory assessment, laboratory confirmation. Next, please. So this is the example of measles case definition. So possible case is fever and rash. You know that measles is a rash illness, febrile rash illness. This is a syndromic case definition, and this is usually for the healthcare worker in the periphery, in community. Probable cases are based on clinical or epidemiological inputs, and these are like physician saying so, or a epidemiologist saying so that there is some outbreak going on in area of measles, and that measles related contact history and other cases that are coming on without pending the laboratory verification can be a probable case. Confirmed cases are based on the diagnostic tool that is recommended for diagnosis. Next, please. So searching for cases to know the extent and the magnitude of outbreak is the next step. So next, please. So these criteria for defining the extent are to be done by maybe enhanced surveillance in the area, and case detections. More case detections need to be done. In time, place, person criteria for case definition are to be considered for searching of additional cases. There are 4 strategies to search for cases, and one is passive surveillance. Passive is something is being done by the local public health agency or physicians, and that is only being passively compiled and reported. Stimulated passive is you ask because there is some outbreak happening, you approach physicians and other facilities and get that passive surveillance data quickly reported and analyzed. That is simulated passive. We ask them to report also quickly and based on this request. Active surveillance is that something is going on and everything is being done by the agency that is interested in getting that data, not the other end. So it is active surveillance, and then door-to-door search is usually done for very important diseases where you don't want to miss a single case in community, because this becomes a very important source for transmission problem. And searches of cases should be everywhere in the same way, not that in one area I'm doing passive surveillance, other area I'm doing simulated passive. That should be unique and similar. Next. So based on this, what we do is we have now a lot of cases that are identified search. We put these cases in a line list. Line list is just the list of cases and database that has a issue of confidentiality also. And you have seen in news that some of the times line list and patients' names and addresses, everything being reported in news. That should not be the case. And WHO has taken their call very seriously. So no more identifiers in news reporting. The investigation, you have to keep that confidential. Maybe some officer is assigned to make that credentials kept secret. Then we do that line list analysis for descriptive analysis and generating the hypothesis. Next, please. So the guiding principles are that it should be a unique ID and unique line list, single line list. That there are various versions, and so versions need to be updated so that there is no confusion. There is a unique identifier for each of the record or case that is in the line list. It should have time, place, person, and clinical and laboratory information. These are the 5 aspects that they should be in the line list. These can be updated as the investigation develops, and then allows regular automated computerized analysis if it is possible to understand how it is going and evaluating the output. Next, please. This is how the line list looks like. A template of line list, unique identifier. Time is on the onset date or admission date you may have. Place can be district, state, ward, block, or actual village. Then is the person characteristics, age and gender. Then the clinical features like what is the diagnosis, what is the hospital where he is admitted, or outcome, whether he died, he or she died or is recovered. And finally, the lab confirmation, whether it is associated with any virus agent or infectious agent identified. Next, please. So generating hypothesis is the next step, and this is done by descriptive finding that we did for line list analysis. We'll see that in detail. Next. So this is the 3 important aspects that we have to do in generating hypothesis: time distribution, place distribution, and person distribution. Time distribution is usually called epidemic curve plotting. Place distribution can be done by 2 ways: spot map and incidence by area map. Person characteristics can be by age and sex-wise case distribution and deaths distribution. There are 2 other approaches for questionnaires of cases to understand exposures in detail. When you don't have any clue based on the descriptive analysis, you do this additional crawling questionnaire and outlier investigations, outlier cases investigation. Next. So time distribution is epidemic curve. It is a bar chart. It is time on x-axis, and unit of x-axis is usually 1/4 of the incubation period. And the number of cases are on y-axis, and no interval is between the bars. That is why it is called histogram. Next. So this is how maybe a routine way of doing the tally marks on different dates, how many cases were there, and then taking that in a different view and plotting that crudely to make it as an epidemic by your hands. But then you can have the softwares now to get that done. And this is the improved version that you are seeing on the right bottom on the slide. That is the gastroenteritis outbreak by hour of onset following the dinner. So that is how acute outbreak and acute onset outbreak could be as a single peak. So next. So now about epidemic curve, description should be for both beginning, how outbreak curve or epidemic curve actually started, how it peaked, is there a single peak or there are more than one peak, how much is the duration of that peak, and how it ended. Okay, and then interpretation of these epidemic curves will help you understand whether there is a point source outbreak, single exposure leading to outbreak like dinner, persistent common source, some maybe food getting contaminated due to the handler there routinely not removed from the duty, that can give persisting common source, or some water or any other environmental source will give this. Person to person is with the public contact, human to human contact, that leads to further cases. Next. We'll see some examples of this. So this we have seen in earlier slide. This is about gastroenteritis or diarrheal outbreak in West Bengal that was initiated by FETP. And this is guided by NI Chennai of ICMR. These are all the illustrations from the presentations that are made to the FETP scholars in teaching and training them in the outbreak investigations. So these are very standard slides. Next, please. So in hepatitis outbreak, this is a persisting common source. So hepatitis this is waterborne hepatitis. So water contamination, drinking water contamination in the underground pipes can lead to this kind of outbreak. This is a persisting common source. This was again hepatitis outbreak. I was part of the team responding to this outbreak, and this is how it looks like a persisting common source. Next, please. So in place distribution, sorry for the interruption. I had actually kept the phone out, but then I don't know how it is ringing. Sorry for that. So place distribution, you have a map to be drawn, and you know that if you are moving to the some affected area, outbreak affected area, you go in the lanes and plot the households and where the cases are happening. This is how a rough plot would look like by hand. Next is next slide, please. So this is the spot map. So plot is of houses where the cases are recorded, and the dots indicate number of cases in each of the house. Next, please. This is then an improved map of incidence by area. So incidence is, you know, by this time that attack rate is one of the incidence calculation attempts per 1 lakh population. So if that is calculated, we divide it into different categories, and then we plot as per the color scale, and we indicate even source of infection likely, like open drains or pipelines crossing the open sewage drains. And the hypothesis can be generated that the blocks with hepatitis there are those supplied by the pipelines crossing open sewage lines. So open drains. That is another important aspect of spot map, helping you identify the source of infection. Next, please. So the person distribution is the next one. So we have to count the cases in each of the age groups you define, and by gender, then divide the total cases in each of the age group and gender by the denominator population you have from the locality. Census can be one of the sources, but the public health staff there would know that how many people live in different hutments, and the structure of age and sex can be also taken from them. Next, please. So in terms of attack rate calculation by age and sex, this is the table giving you the age specific and sex specific attack rates calculated. Number of cases divided by the total population, that gives you attack rate. So here you are saying that 0 to 4 years is giving highest attack rate, and total is 4.9. So actually, definitely this 0 to 4 years, there is specific something that is causing the outbreak. That is a measles outbreak happening in that area. Next, please. So in short, about the crawling questionnaires to generate hypotheses, these are open-ended questions that you go and talk to people, those are affected, those are not affected, and see their activities, their contacts, their exposures, and then see whether they are similar or different cases as non-cases. And in a specific event, they had participated in their own understanding that what could be the reason of this outbreak that is happening in that community. So getting community involved and engaged, this will help really in getting their support for outbreak control activities also. Next. Then is the outliers. As we see, outliers can be also the source of infection. So someone traveling from abroad, coming here and then infecting others because he is not aware of he is infected or transmitting. Definitely, these are also important aspects to investigate outliers. First few cases are to be investigated in detail. Next. So we need to continue monitoring the situation. We cannot just go and come back with whatever 1 or 2 days of investigation. Trends need to be monitored. Control measures that are being implemented need to be actually looked at and maybe recommended for changes, if any. Logistics, continued logistics support, and other community involvement activities need to be considered, including media engagement. This is very important nowadays because media actually is in search of sensational news, and that is what their purpose is, to make people understand that this is a very important aspect. But we have to keep that in mind and engage media also in better education and communication of communities so that we can take care of outbreak control and decreasing its impacts. Next, please. When to declare the outbreak is over is important activity, and that is usually done by the medical officer of health there in that area. And that the criteria, epidemiological criteria, is that there are no cases from the last case until 2 incubation periods from the last case that has happened. And it includes, and it is important that the case search is continuing in the same intensity. That it should not be that the last case is today and 14 days I don't work for 2 incubation periods. It doesn't mean. So you have to have a continued support and surveillance going on. Next, please. So testing the hypothesis, these are advanced epidemiological analytical studies that we can undertake. Some of the times this is a research activity. Some of the times it is important for our outbreak control itself to guide and control the impact. Next. So these are important aspects in terms of hypothesis generation to hypothesis testing. That is the move that we have to take in this. We have generated hypothesis. We are likely then considering this for testing in analytical designs. Next. So we have to define objectives, write mini protocol, and define the exposures that you think based on generating hypothesis aspect that you have done, which are likely to be associated with this outbreak. Next. There is a choice, and usually the case control is preferred because we don't have time enough to follow this code further and see how it will go on. We are not started before an outbreak started for investigating as a cohort. So mostly the case control is the preferred choice in outbreak investigations. Next. This is the format or content of mini protocol that you can develop for the analytical studies. Next. So interpretation again is to be very cautious. Is this association true? Is this strength of association meaningful? Is there a statistical significance attached to the analysis that you are making? And is there a specific causation that you can think of based on different causality criteria? Is there a single source, or there are many other sources that are likely contributing to outbreak? Next. So this is attack rate. This is one of the examples of analytical study that was undertaken in a very well characterized outbreak. So raw custard was identified as the risk factor for the outbreak of gastroenteritis in West Bengal in 2005 by the India FATP. Next. So then we have to draw conclusions, 7th step. Next. And in concluding the investigation and conclusions from the investigation, whether the source of infection identified is helping you explain the descriptive findings is important aspect to be considered. So that whatever you say now, this is the source. Source that is identified should explain most of the cases that are happening in the outbreak. We have to follow up on the source of infection, maybe intervene. If there is a well contaminated, you can take care of measures, stop the well water use, or maybe chlorinate or alternate source. And then if that is taken up, how it impacts the case, actually the outbreak evolution. That also is another pointer that it is really the source of infection. You can have environmental study, you can collect water, food, and other samples or in sewage, sewage if it is so source of infection. Trace back, we can actually investigate back retrospectively the cases with the source of infection track for them. Then is the laboratory evidence. You can have non-human samples, environmental samples also in support, and get that also sequenced and see if the sequence is same from the environmental sample and human samples. Next please. We have to then compare the hypothesis with the established facts. So whatever you have come up with, this is the source and this is the mode of transmission, this is the actual risk factor that is contributing to outbreak. Is there similar kind of literature saying so that this, say, like a onion and related hepatitis C outbreak is very well known outbreak in literature. So onion peels and contamination of onions leading to hepatitis C outbreak. So similar kind of exposures, if it are reported in literature, that helps substantiate your findings. But maybe that some of the investigations you have the unique thing that you are detecting. It is not like that you should always be considering whether it is in literature or not, but you should be able to explain most of the cases happening. Next. So these are the sources of established facts. You can talk to the headquarters or supervisors like IDSP experts. You can have literature review, what is published on hepatitis C outbreaks if you are interested in so. Mainline search, you can search for the published articles, and then internet, whatever non-peer reviewed literature also can be considered. Next. So we can add, actually have additional studies undertaken like laboratory studies, like typing, variant detection. All these can be additional investigations that can be planned, studies can be planned in outbreak situations. We can have environmental studies, anthropological studies, very important nowadays with COVID and other behavioral risk factor related outbreaks. So there is definite need of social sciences, anthropology, and social science inputs for identifying the behaviors and risk factors that are actually helping cases leading to larger outbreaks. Health economics is another area where you can actually have evaluation of economic aspects of outbreaks and impact on human health. Next. So then we have to communicate the findings of your investigation. Next. So these are various ways we can do it. Preliminary report is usually as a written report and should be left in the field when you move out of the field. So you have to debrief your investigation findings to the collector or health officer, wherever and whoever is required to take action and continue control activities. It should be short enough, preliminary, with a disclaimer. This is a preliminary because this is not the final finding. Then factual. It should be based on the facts and report findings, not as a theoretical recommendations. Several formats can be used as abstract, slide set, bulleted list, or table. That should be understandable by the local public health authority or administrative authority in case of collector if he is actually managing and controlling this. Next. Final reports could be, you can present that in our conference in the researcher group, academia public health conferences. Then you can have a manuscript paper finalized and submitted for the research audience. And then you can have a epidemiological bulletin report also. There are various bulletins released by different agencies on outbreaks that they have dealt with, including NCDC of IDS. Next. So 10 is exiting control measures that we'll think of, and this should be very specific. Next, please. There could be general measures that you can think of, standard. You know that this is waterborne, water-related practices need to be improved, wash interventions, all this. But then what is important is you should be having data enough in support of that control measure that you are recommending from the investigation. So that is how evidence-based decision making and reporting is important. Next. So control measures for an outbreak can be general and specific based on the agent you identified, environment, or specifically targeting the transmission, curtailing transmission, or protecting severe disease, protecting people from severe disease and untimely outcomes, or maybe unexpected outcomes like death, then in case case management related observations also could also be considered, that this case can be managed in various different changes that we can make to management protocols. Next. This is very important because prevention measures need to be continued. In spite of report is given, everything is done. And these are to be, prevention measures are to be based on evidence. This should be specific, feasible, cost effective, acceptable by community. Very important. You can recommend anything, but the public is not interested in making that, like mask use now. So if you are recommending so and not enforcing that, then maybe public is not willing to continue that activity as a preventive. So in that case, and ethical also. There are some restrictions that are put in outbreak investigations. There would be issues about public health ethics also. Next. So then another aspect is that you can evaluate your prevention measures that you applied. What was the additional effort, input that was put in, how many processes were managed with how different support systems that needed, what was the output and outcome, whether this helped prevent the outbreak magnitude and impact, decrease the impact. That is another aspect that we can think of as public health evaluation measure. Next. So then just in short, maybe we have 5-10 minutes, we'll move to the laboratory roles and responsibilities coming from public health laboratory like NIV. It is the most important aspect that the laboratory contributes, and we are here to make that and facilitate in NIV and ICMR. So role of a laboratory is, next please. So before, there are roles for our laboratories in different phases of outbreak. Before the outbreak also, we can keep tab on what are the different signals that are coming on, which are the alerts that we need to look for and seriously consider verification and investigation. Then we can help actually the laboratory to identify unusualness in whatever is being reported to laboratory or maybe reported back to the public health and clinical medicine. What is unusualness in that? What is usual and unusual is a very difficult task to undertake, but that is again with consultation with the public health and clinical medicine experts. We can consider during the outbreak, laboratory can support the outbreak response and management by diagnosis and other research activities, or even you can evaluate your measures, countermeasures for outbreaks like diagnostics, your vaccines, and the drugs also can be evaluated whether this is helpful in outbreak situation. We are seeing in COVID that many of the intervention tools are being considered to respond to the pandemic. In between outbreaks, you can continue monitoring trends in different areas you are interested in. You may have heard of hotspots, and there are activities that we can undertake in hotspots to understand what new virus agents or any other agent, infectious agent threat is coming on or likely to come on. So we have in place the activities between outbreaks also to monitor and intervene. Then is intervention evaluation also can be undertaken. So the way we responded to specific outbreak, did it help decrease the impact of that outbreak in any way and to what extent? Next is monitoring progress towards a control objective, that we no longer have the number of outbreaks that are going down, or maybe the impact of outbreak is going down, the mortality or severity of disease is going down. All these measures can also be considered with the help of laboratory support. Next, please. So laboratory, next, laboratory can get engaged in early cases. Only a subset of cases are needed to be confirmed. As you see, new outbreak happening, first few cases need to be laboratory confirmed. And based on that, what we define is a probable case, because most of the time it would not be possible for public health to put that resource into the diagnosis itself, because there is then competition between prevention control activities, surveillance activities, and other aspects. So then diagnosis can be limited to unusual cases, and then these definitions can be streamlined and used for probable cases for the control measures. Then we can have the identification of new pathogens. If there are co-detections, you have seen that most of the time will also be possible that there are various agents being detected in the same outbreak. So this is like co-detection or co-infections. Then typing of the pathogens to characterize whether the virus is changing, agent is changing, and then also it helps in linking the clusters. So it is like genetic characterization and mapping to see if the variants or the genome that is detected in one case is related or similar to the other. So as to have that contact information established and link the contact. Antimicrobial susceptibility also can be helpful in especially bacterial infections and viral infections where antivirals are available. Post-outbreak surveillance can be continued till end of outbreak to characterize the outbreak in terms of time plus person and clinical epidemiological features. Environmental investigations also can be supported by the lab with all environmental sample related testing as an indirect evidence. And then carriers, some of the diseases may have carriers, infections may have carriers. So you have to have that laboratory support to maybe label that as a carrier, continuing transmission without having symptoms. Next, please. So here there is not much been discussed because of lack of time. But ultimately, the aspects are the scenarios like the known disease outbreaks. The very well characterized diseases like dengue and chikungunya. These are usually very easy to manage. These may pose many problems because you know what it is caused by, what are the likely risk factors. You directly can start controlling. But in case of unknown etiologies outbreak, that is very difficult to understand what is the transmission, what is the likely agent involved. And in that case, this is a very important issue and a testing time for the public health agencies or investigating agencies. And media also is looking for competence and other issues, whether this system failure or it is like all these questions come on. So in that case, we need to be very cautious in dealing with media and even trust and faith of community in public encounters in outbreak investigations. We need to keep that intact because ultimately most of the outbreak investigations and control activities depend on local people. Their information that you are getting, their engagement in prevention control activities are important. So that is what I think is public health ethics issue, and we need to manage that very clearly. Knee-jerk reactions are not to be considered. We can just label something as a syndrome, but then ultimately we should have all efforts done with clinical medicine experts that this is definitely a new syndrome, not a known disease that is presenting differently and behaving differently. That should not be the case. And then important aspect that needs to consider to the case definition. If you are young researchers and master students, this is a very important issue that whenever you are dealing with outbreak and you are getting some involvement in this, you should be very careful about the case definition, selection of cases for investigation, representativeness of cases, and ultimately then generalizing the findings to total outbreak understanding. And important contributions that you can make is in a laboratory. If you are I know that some of you are from life sciences, master students, and some public health. Definitely, this is an important aspect that you need to consider. Thank you.
Thank you so much. It was an excellent and very informative, very lucidly given lecture. We really enjoyed listening to this, and I'm sure the participants have understood basic steps to be taken in outbreak investigation. Sir, some questions have already come here. I would like to ask some of the questions. First question is, if background rates are not known, how do we talk about outbreak?
Yeah, actually this is possible if the IDSP syndrome list doesn't cover that syndrome. But usually another few syndromic approaches are also considered, like acute encephalitis syndrome, viral hemorrhagic fever, or maybe acute febrile illness. All these syndromic features are also there. And if this is, and there would be definitely issues in availability of data some of the times. That is, I'm not saying so that everything is available when you move into investigations. So if that is not available, we can actually consider the usual rates that are reported for a country like India.
Okay.
Or Maharashtra. Maharashtra, say some district it is not available. Other district is it available? Okay. That is maybe as an alternate data point you can use as a comparator. But then you can definitely these are like quantitative aspects. But if you say only talk to people, they will say that this is unusual. This has not happened in last few years here in this area. Definitely it is unusual. So that I think is important enough to go ahead and investigate in it.
Okay. Okay. Thank you. Next question is, could you please again explain stimulated passive surveillance?
Yeah. So as I explained, passive surveillance is what is being routinely done. Say, like, I'll give you an example that sentinel surveillance, if some of the scholars and students have heard, sentinel is something is being done in some community or some hospital setting to know what is the likely occurrence in that area, right? And this is likely to be not the intense surveillance that is going on, but get to know that what is the likely expectation in that area. So for JE, if you consider that, this is mostly done by sentinel hospital surveillance, and some of these samples are taken to the lab. So if you say
Japanese encephalitis.
Japanese encephalitis, so if it is happening like a syndromic surveillance, then supplemented by the laboratory surveillance and diagnosis whenever possible. It is not a mandatory thing. So if it is simulated passive, if I support this, that all the samples that are coming from AES, acute encephalitis syndrome, I can test them. Program decides so because there is no enough resource available, testing capacity available. If I contribute that and make that happen with additional support from different agency, that can be simulated passive. Okay. Another aspect in the community level could be simulated passive is that now if you see, and Dr. Aute has taken the lecture, I think how surveillance happens, SP and L form. If these SP forms are being actually compiled and analyzed, you know that some of the areas are not reporting the forms timely, or there is issue of data quality. You can get back to them and ask them to get that quality data, at least in an outbreak situation. If there is something or a season that you know, outbreak season, at least you start maybe surveillance improvement. So that is how it is stimulated passive.
Okay, okay, that's very nice. The next question is, if attack rates are different in different areas, how do we interpret these results?
Yeah, because I think attack rate takes care of the denominator. So you have comparability. If you are calculating attack rates in different villages, you have a population denominator there and cases that are on record till whatever date you are interested in. So I think attack rates are comparable. You can take care of that attack rate comparison easily with the population denominator available in the health staff.
Okay. And the next question is related to this. Like, what is the difference between attack rate and incidence rate? Why do we require to calculate attack rate?
Yeah, actually in incidence rates, what we need is a cohort. So we need to know what is the population at baseline and how this population experienced different exposures and led to disease development and how many developed disease. So there is always a prospective approach. In attack rates, we assume that the population is constant, or whatever population now in thick of the outbreak is actually the population that was residing in that village or that locality earlier also. So that is a retrospective approach. Ultimately, it is an alternative term, but attack rates are taken as incidence rates for the outbreak investigations, definitely, because we are interested in attacks.
Okay, okay. How to forecast an outbreak, which is a
this is tough question, and ultimately there are issues that you have seen on COVID, that people saying third wave will come in August, third wave will not come in that intensity, third wave or fourth wave, or it will become endemic. I don't want to comment on this COVID aspect, definitely, because there is a very uncertainty attached to that and issues associated with different levels of scrutiny and understanding also. For the forecasting, definitely you have a modeling approaches. Prediction is considered. So you need to understand the quality of data first before we actually launch into predicting something. And there are various assumptions. That assumptions are based on what you know at the time you are trying to forecast and predict. So there are always difficulties in arriving at assumptions, and the estimates could be heavy. Mainly this can go to that end or this end. So sensitivity and actually utility of the modeling will depend on the quality of data and quality of assumptions based on evidence.
Okay. So do you think in this situation, surveillance system will be of some help? Not forecasting as such, but giving some indication about changes.
Yeah, that is what is the data quality, surveillance data quality is about. So if you are very sure that these are the actual numbers that are actually having on record, there are not missed cases. There is complete truth and validity in the data that we have, and we can rely on that data. Definitely, we can try that with our additional modeling methods.
Right. There is one more question. How time and place interaction is identified in outbreak?
So what you do is, if you have maybe some talk earlier, I don't know, spatial temporal analysis you can do. So what you can do is you can plot. You have seen our world in data sites. Most of you may have been too. So what they do is actually they give in time, but they have the plots that are actually running plots like GIFs. They will have that maybe map, and then the cases are again projected over time. So spatiotemporal analysis definitely can help.
Okay. Okay, then there are a couple of questions which you can choose or not to answer or not to answer. Do you think the reports of outbreak taken seriously by policymakers?
Okay, why not? I think if your investigation is good, your findings are with quality data that you have got from the public health system. There are issues in quality in outbreak because it is called dirty and quick epidemiology. If you want to understand epidemiology, you do an outbreak investigation of some syndrome, you get to know most of the things. But then you will get to know the issues also attached to that. So what is important is it should be clean data and quick also, because outbreaks require you to act very timely, quickly. Yes. Yes. And that is why the quality of data, again, I will emphasize that is important.
Right. Sir, just one more question. I know we are beyond 12 o'clock, but still, do you think that finding just one case, for example, Zika case in Purandar,
yes,
can that be considered as an outbreak?
Yeah, for the specific issue, if you are saying so, in terms of the recent event that happened, the background is that this was some fever outbreak going on. So dengue and chikungunya samples are usually collected by public health system and referred to NIV for testing or for their own laboratories testing. So there were few cases positive dengue chick also, and one of the case was positive for Zika. So this was based on PCR detection. So definitely there is competence. Vector is same. These are 3 viruses that are carried by the same vector. So there may be a possibility that this virus is there in nature. This is there, but this is not actually amounting to and competing with likely to compete and help make it as an important agent. But definitely we have to keep track and follow it up to see how it goes on. So we cannot say that it will replace or it will compete with others and it will become an important virus agent causing outbreaks. But it is to be kept on hold and investigated and understood in future.
Okay. Thank you so much. Questions are endless, but we have to stop somewhere. We thank you immensely for your presentation and answering all the questions. Thank you once again, Dr. Tandale, and we look forward to more interaction in next course, maybe when PKC decides to have another course. Thank you so much.
Thank you so much for this opportunity. I actually enjoyed a lot interacting and talking to you and the questions, responding to questions. Definitely, these would be important for me also to consider in future research endeavors. Thank you so much.
Okay, thank you so much. Thank you. Prachi, we can stop recording.
Yeah. So, yes, we'll stop recording, but I will just keep the meeting on. If people have not filled the attendance, please kindly fill and then leave the session.
Okay.
Okay.
Thank you. Thanks.
Thank you.
Thank you.